This lecture is going to be on causes of hyponatremia and hypochloridemia. This figure is a summary of sodium and chloride dynamics in the body. Sodium and chloride are acquired through the diet, and sodium and chloride can shift between the blood and the intracellular space. It can shift between the blood and third spaces, such as the abdominal cavity. And sodium and chloride can be lost in the GI tract, kidneys, and skin. The two general causes of hyponatremia and hypochloridemia are increased loss and shifting. Decreased intake does not cause hyponatremia and hypochloridemia, and that's because there's an abundant amount of sodium and chloride in the diet, and sodium and chloride are highly conserved by the kidneys if the kidneys are able to function appropriately. Sodium and chloride can be lost in excess by the GI tract, the kidneys, or the skin. Excessive loss by salivation, sweating, burns, or wounds can only be confidently identified with historical findings or physical exam findings. Vomiting is supported by the presence of a metabolic alkalosis due to a loss of hydrochloric acid-rich gastric fluid. Diarrhea is supported by the presence of a secretional metabolic acidosis due to a secretory diarrhea. Renal loss of sodium and chloride can occur with renal failure, hypoadrenocorticism, diuresis, and ketonuria. There are 4 mechanisms for renal sodium and chloride loss. Renal failure causes a decreased number of functioning tubules. The flow rate is increased with causes of diuresis. Osmotic diuresis may occur with glucoseuria, ketonuria, or the excretion of ethylene glycol metabolites. Or diuresis may occur with any other cause for diuresis. Diuresis results in an increased flow rate through the tubule, and this allows a decreased time for sodium and chloride resorption. Anions attract cations, and sodium is a cation. So, if there are excessive excretion of anions, such as ketoanions or ethylene glycol metabolites, then the anions in the ultrafiltrate attract sodium and retain sodium in the ultrafiltrate. Hypoadrenocorticism causes sodium and chloride renal loss due to a low aldosterone activity. Aldosterone normally acts on the kidneys to increase sodium and chloride resorption, so its absence would lead to less sodium and chloride resorption from the ultrafiltrate. Concurrent findings with hypoadrenocorticism include lack of a stress leukogram, so no stress. Also, you might see hypoglycemia, hypocholesterolemia, as well as hypercalcemia and hyperkalemia. Sodium and chloride shifting out of the blood vessel can occur with uroabdomen or rhabdomyolysis. Urine has high concentrations of potassium, phosphorus, urea, and creatinine relative to blood. However, the blood has higher concentrations of sodium and chloride relative to urine. So when urine is in the abdominal cavity, then the concentrations of these substances equilibrate. In doing so, sodium and chloride shift from the blood into the abdominal cavity, causing hyponatremia and hypochloridemia. And potassium, phosphorus, urea, and creatinine shift from the abdominal cavity into the blood, leading to increased concentrations of all of these substances in plasma. The major intracellular ions are potassium, phosphorus, and magnesium. The major extracellular ions are sodium, chloride, and calcium. Muscle cells also have high concentrations of the enzymes creatine kinase, or CK, and aspartate aminotransferase, or AST. Muscle cells also contain myoglobin, which helps the cells to acquire oxygen that they need for aerobic metabolism. When there is muscle cell lysis, then the substances at higher concentrations inside of the cell are released into blood, and this causes higher concentrations of all of those substances in plasma. Also, ions at higher concentrations outside of the cell shift from the blood into the dead space that's left by the lysed myocyte. So you'll see decreased concentrations of sodium, chloride, and calcium.